Welcome, participants, to the 5th Annual MCBK meeting. This is our first global and third-year virtual. I'd like to thank the program committee, the presenters, and the meeting staff for their help in making this meeting possible and arranging what you're going to see as a fantastic program. This is a 2-day event with 2 sessions each day to accommodate our global participants. The session today will be about 4 hours long. You can see right now the time around the world. It's 7 p.m. in Eastern North America. It's 7 a.m. in China and 9 a.m. in Australia, where I am right now. Over 500 people have registered for this meeting and will be joining at different times depending on their time zones, and they represent 41 nations. I'd like to introduce the co-chairs of this meeting, and we'll start with Chuck Friedman.
Greetings, everyone. I'm very pleased to be here and to be co-chairing the meeting with Wendy and Philip. I'm Chuck Friedman. I'm the chair of the Department of Learning Health Sciences at the University of Michigan.
And Philip.
Hi, thanks, Wendy. I'm Philip Scott. I'm co-chair of the UK MCBK activity. I'm Programme Director at the University of Wales, Trinity St David, and I'm chair of the British Computer Society Health and Care Group.
And I'm Wendy Chapman. I direct the Centre for Digital Transformation of Health at the University of Melbourne in Australia. All right, this is the first global meeting where we've had sessions at different times to accommodate all of us so that we don't have to stay up in the middle of the night to watch the wonderful talks. It's a 2-day meeting, and as I said, it'll be 4 hours in duration. A recording of this session will be available soon after it ends, and the recording of session 1, which occurred in the morning of the US Eastern Time, is already available. So after this session, you can access those keynotes and lightning talks. You have joined on the IBM meeting platform, and we will be spending time together on that platform. You'll be able to enter questions for the keynote talks through there. We will be using Zoom for breakout sessions, and we'll talk more about that later. So let's start with why we're here. We're going to talk about, the imperative of fair and trusted computable knowledge. And Philip is going to give us that introduction. Chuck's going to talk about a brief history of MCBK, and then we'll give an overview of what's to come in this meeting.
We're focusing here on a very famous quotation, a very powerful paper by Geoffrey Braithwaite, one of our keynote speakers at this conference. And he spoke about the 60-30-10 challenge. And that's based on the fact that 60% of care is in line with evidence or consensus-based guidelines, 30% is some form of waste or low value, and 10% is actually harmful. And this is not a new thing, it's not a temporary thing. This is a phenomenon that has existed for decades, and this is not the only paper to make a similar argument. So what's the role of MCBK in addressing this well-known and established problem? So let's think about what's the problem we're trying to solve. Now, this diagram is structured around decision support, and decision support we think of as primarily something which exists in the clinical front line when we're making healthcare decisions with patients or for patients. But of course, MCBK, as we'll emphasize in a moment, is a multi-domain activity, not just at the clinical front line, but also covering use cases in public health, in research, and in education. But many of the same drivers apply across those spaces. So we think about the changing workforce. So we have the phenomenon of different workforce in healthcare delivery, new roles, for example, like physician assistants and taking on responsibilities which perhaps previously were only for fully qualified physicians. So the workforce changes, there's known phenomena such as diagnostic error and the sheer volume of diagnostic data which now has to be dealt with in reaching decisions. And then there's outside pressures, so the technology push which in itself is affecting patient expectations, public expectations, staff expectations of how decisions are supported. And the fact that current decision support has had some impact, but perhaps not the level of impact we would like to see. And then in the healthcare space, the increasing multi-morbidity of the aging population in most of the developed countries. And of course, as we alluded to with the 60-30-10, the simple fact of non-adherence to guidelines. So something has to be fundamentally different. So this meeting is primarily about knowledge and only secondarily about data. So what's the distinction? We hear so much about data. Why are we talking so much about knowledge? Well, one way to think about knowledge is that it's something useful. It's the result of an analytical and/or deliberative process that has some significance for an identified community. And to kind of counter a widely used but frankly misleading expression, data does not save lives. Knowledge can, because knowledge can affect how decisions are made. And we think then about examples. Well, what is this biomedical knowledge that we want to mobilise? Well, it is a spectrum. As we've said, it's analytical and/or deliberative. And so we can think about things such as various kinds of models, predictive or explanatory, computable phenotypes to identify particular disease groups, networks which can be causal or propositional, guidelines we've mentioned, best practice, clinical practice guidelines, as well as decision trees, and indeed policies where we think about organisational or service practices. So they are all examples across the spectrum of what we mean by biomedical knowledge. And so then we think, well, how do we represent knowledge? And of course, the left-hand side is traditionally how we represent knowledge in a human readable way. We use words, we use pictures, we use equations, we use numbers, and they are put together in written and until fairly recently printed publications, which are then placed in libraries and become the authoritative knowledge base. What we're saying as the vision of the future is to think about computable knowledge, not just computer readable, but computer implementable, machine implementable knowledge as being the new content in libraries of the future. And so then we think about the learning health system concept, the continuous improvement cycle, where we see at the centre a health problem of interest, again linked to the idea of knowledge as being something in a community of practice. And so we have the knowledge put into practice, the K to P section of the cycle. Knowledge is used to improve performance or activate performance. And then data is captured as a result of that performance, the P to D section of the cycle. And then once that data is captured, we then produce the knowledge from it, whether it's the knowledge that's been produced for the first time or whether it's knowledge based upon the result of some improvement that's been implemented. Data to knowledge, and then back we start again. And as we've said, this is something which applies across multiple domains, both in healthcare delivery itself, but also in areas such as public health, population health, and broader the research pipeline, going right back to commissioning and design of research through to educational functions. So the concept here, the proposition of MCBK, is that knowledge is the kind of keystone that holds this cycle together. It's the knowledge that is moving around that pipeline and that is making the change happen. So this is the translational problem. At the moment, that keystone doesn't really exist apart from in the traditional literature. And so hence we have the 17-year gap that sadly we know is an ongoing problem, that knowledge is created but then not put into practice for a considerable time. That is the gap in the learning health system cycle as we currently see healthcare. So the proposition here is that we need to close that improvement gap through the use of computable knowledge. That is the enabling keystone as we move forward. So to achieve that requires infrastructure, in the same way in which over the years we have developed the concept of libraries to curate, manage, and disseminate traditional knowledge. We need that kind of comparable infrastructure and architecture to support this computable knowledge ecosystem. And in the same way in which we think about traditional research and knowledge, applying these FAIR principles, again, this has to be something used for computable knowledge. It has to be findable, accessible, interoperable, and reusable. That works in terms of our traditional human readable knowledge, but we have to find ways to make that work for the computable knowledge ecosystem. So we need this infrastructure. It doesn't currently exist. And it doesn't just need to be fair. We need to go beyond that and think about the concept of trust. Because if this knowledge is simply there in a kind of abstract sense, but has no trust, well, again, we won't see implementation. The translation gap won't go away. So we are saying that the world needs to mobilize computable biomedical knowledge. So let me turn back to Chuck now to take us through a brief history of MCBK.
Thank you, Philip. Thank you very much for that summary. I'll speak now about something that has been done up to this point. I do believe that Philip was correct in saying that the infrastructure we need doesn't exist, but it's also not entirely absent. To make that a bit more clear, the infrastructure in its entirety does not exist, but pieces of it exist, and some of it exists because of the efforts of the MCBK community over the past 5 years, and I'll tell you a little bit more about that. MCBK is a movement. It is not a formal organization, at least not at the moment. This is something we'll discuss tomorrow. It is a multi-stakeholder movement. It does not just consist of informatics scientists, although they are very important to the movement, but it also consists of people who consider themselves to a large extent to be care providers, managers, payers, government officials, and others who have an interest in attaining better health and see the potential for MCBK to advance the world toward that goal. Now, the movement is 5 years old. It began with an invitational organizing meeting that took place in Ann Arbor, and there you see a picture of the famous University of Michigan bell tower. The meeting in Ann Arbor, as I said, was invitational, and it was held to verify or not that this idea of MCBK had potential. The meeting was successful in the sense, first of all, that people came, and second, and of course, much more important, that it verified that this idea of MCBK was indeed an important idea, and people were willing to devote time into making this idea work and moving toward the infrastructure to make computable knowledge fair and trusted. The initial meeting was followed by open in-person meetings, meaning anybody could attend. And in those pre-pandemic days, it was possible to have the meeting face-to-face. And we were very fortunate to have a significant interest in MCBK shown by the U.S. National Library of Medicine, which is part of the National Institutes of Health. And we held 2 meetings in the building you see there on the slide at the NIH in 2018 and 2019. And these meetings were well attended and really quite successful. Now, a very interesting thing also happened in 2019 based on a growing interest within the UK in computable knowledge. a meeting was held in London in 2019, organized by Philip Scott and Jeremy Wyatt, and very, very well attended, which launched a movement, we could call it, specific to the UK, to also move toward making biomedical knowledge, computable biomedical knowledge, fair and trusted. And the picture you see there is a picture of the late Dr. John Fox, who has been instrumental in much of the science on which computable biomedical knowledge is based. Very sadly, John Fox passed away last year. We miss him terribly, and were he still with us, he would be participating very actively in this meeting, and maybe in spirit he is. I encourage you all to read a very wonderful memorial article written by Jeremy Wyatt about John Fox, which has been published in the Learning Health Systems Journal, and you see a reference to it there on that slide. The pandemic struck in 2020, and as a result, the next two MCBK meetings were open, of course, but they were held virtually. They were also well attended and very successful on the whole. And this led us to the idea of a virtual meeting that visualized, as we are doing right now, a global MCBK movement. And this idea was really sparked by the meeting that took place in the UK, which suggested that if there is interest in MCBK in the US and the UK, there is potential for this idea to take hold around the world, because the challenges to health are global and universal. The 2018 meeting had a very, very important outcome. You recall this was the first open MCBK meeting, and we felt it was necessary to construct a document that would express what MCBK was trying to accomplish. And we somewhat ambitiously, but I think appropriately, called this document a manifesto. And a lot of the 2018 meeting was actually devoted to reaching consensus among the attendees about what this manifesto should say. Work at the meeting was done to sharpen and finalize, or almost finalize, the language of the manifesto. And then following the meeting, some interactions occurred to finalize the document. Here you see a picture of it that is probably too small to read, but there's a link to it in the meeting materials. Now, I've excerpted from the manifesto, the MCBK vision, which is expressed in 4 points, and I'll go over them because I think they're very, very important to understanding what MCBK is all about. So from the 2018 manifesto, one big part of the vision is the idea of, as the name says, mobilizing biomedical knowledge that can support action toward improving human health. And here the manifesto expresses the point that Philip made earlier, that this can be done, and may be best done or most efficiently or scalably done, using computable formats that can be shared and integrated with existing health information systems and applications. The second aspect of the vision is the idea of efficiently and equitably serving the learning and knowledge needs of all participants, as well as the public good. And here we see the very important point that MCBK and the potential of computable biomedical knowledge should be used to reduce the well-established and well-understood, but very hard to correct, disparities in healthcare that exist around the world. Third point was ensuring that the knowledge that is made computable and made fair reflects the best and most current evidence and science. Knowledge that is not valid, knowledge that is not up to date, will not result in making everybody or anybody healthier. So in order to ensure that computable biomedical knowledge put to use actually makes people healthier, it has to be valid and up to date. And finally, the fourth component of the vision is to do this through an open computable biomedical knowledge ecosystem dedicated to achieving the FAIR principles. So FAIR, this concept of findable, accessible, interoperable, and reusable is very, very central and should permeate everything that MCBK does. So what has been achieved so far over these 5 years? Well, actually quite a bit, and we're very pleased with this. And you'll hear a little bit more about this in this session tomorrow on day 2 of the meeting. MCBK has resulted, we believe, in a community and a substantial community and a multi-stakeholder community that is bound together by the principles expressed in the manifesto. It has achieved a level of interest that has spread around the world. There are 41 countries represented in the participants in this meeting as some evidence of that. There is a relationship now between the Learning Health Systems Journal, published by John Wiley and Sons in the United States, of which I have the honor of being the editor-in-chief, and MCBK. So several aspects of what MCBK does will be published in the journal. And some examples of that include a report on each of the annual meetings beginning in 2019 that are published in the MCBK journal, and also beginning in 2020, I believe, all of the abstracts that are presented at the meeting, and this will be true of this year's meeting as well, are published in full in the journal, so they can be cited and by the abstract authors, and they can receive publication credit for that, in addition to these abstracts now being accessible to the rest of the world. There also have been several very specific deliverables, a very important paper and ongoing work on CBK metadata was recently published in the journal. A white paper from the British Computer Society, authored by Jeremy Wyatt and Philip Scott and others, called Building a Clinical Sat-Nav for Practitioners and Patients, has appeared and has attracted a great deal of attention in the UK, and we are disseminating it now in the US. It really is an excellent piece of work. And other studies have appeared, including a recent study of CBK repositories, which are a key part of the infrastructure for making computable biomedical knowledge fair. So this concludes that brief history of MCBK, and now I'll turn things back to Wendy, who will give us an overview of this meeting and what's going to happen in the next few hours and tomorrow.
Thank you, Chuck and Philip. Let's talk about what's going to happen today. All right, so each day of the meeting has 2 sessions. We are on day 1, but session 2. And here we are. It's 7 a.m., 7:26 a.m. in China and 9:26 a.m. in Australia. And Chuck and Philip on the Eastern time zone in the US are staying up late to be with us today. So we're really happy about that. And I'm guessing that there are probably some people who are in the Pacific time zone who would prefer to join at 4 p.m. rather than at the early hours that they would have had to join on day 1, session 1. We can see here how it's been organized to be able to suit people around the world in different time zones. All right, so in this entire MCBK meeting, there will be 6 keynote presentations with discussions. On day 1, there are 4. There were 2 given earlier, and there will be 2 today in this session. In day 2, we'll have 2 additional keynotes. On this day, there are 10 lightning talks in each session, and there'll be very brief 3-minute talks that are recorded and shown in sequence, and they'll be followed by small breakout group discussions with the presenters. And so you'll choose the lightning talk that you were most interested in and join the breakout room with a Zoom link that will be presented to you to join a discussion with that author. On day 2, instead of lightning talks, what we're going to have is thematic huddles, and we'll have 11 themes that you can choose from. You'll get to attend 2 of those. And finally, we'll have a closing session on day 2, which will be a discussion about how do we move ahead with MCBK in a global manner. All right, so in this session, we're currently in the introduction to the meeting. We will have a keynote today by Graham Grieve and Bryn Rhodes and a discussion. Then that'll be followed by 10 lightning talks. Then you'll go into breakout rooms to discuss with the authors the topics of their lightning talks. We'll have a 15-minute break at that point, followed by the second keynote, which will be given by Lu Xiaozhang and Guilan Kong. And then finally, we're very lucky to have Enrico Cuera watching on, and he's going to summarize the session for us, and then we'll have a close and a look ahead to the next session. Just some technical logistics. During the keynotes, please submit your questions as soon as you think of them. Use the Q&A option in the IBM platform that you're in and type them in. And type them in early because they have to go from the IBM platform into Zoom, to me, or whoever's hosting it so that we can manage those questions. You'll be in the IBM platform during the plenary sessions and in Zoom breakout rooms for the lightning talk discussions. And that will really help us be able to have interactive discussions where you can ask questions and talk and argue, which you can't do on the IBM platform except through the Q&A. Below the IBM video player, you can see the links to the Zoom meetings. And there's a video tab that has links to the recordings. And you'll see that the recordings from session 1, day 1, are already available there for you to watch later. And the recordings from this session will also be added there soon. All right. So with that, there's so much to talk about. There's so much to do in this space, so much to learn. And so we're going to move onward